Thanks, Jenny, for that introduction. I just thought I'd introduce myself to the viewers. I'm Lisa Creighton. I'm a oncoplastic breast surgeon based on the Sunshine Coast in Queensland. I look after an awful lot of breast cancer patients in my practice, and through that practice have come to know a little bit about lymphedema and the significance of that for our patients, and what we as clinicians might be able to do to improve their outcome. One of the reasons that I like to refer my patients for a pre-treatment baseline L-Dex assessment is because patients do have a valid concern about developing lymphedema with their breast cancer care. Sometimes that anxiety is even to the stage where it's bordering on a par with their anxiety about having breast cancer. And if we can do things to alleviate that anxiety, it can make their journey through the breast cancer treatment a lot easier. So as the treatment of breast cancer has evolved, we're certainly doing less treatment that causes lymphedema. Certainly surgically, which is my area of expertise, we do a lot less axillary dissection where we are clearing all the lymph nodes and instead are just taking 1 or 2 lymph nodes away, which certainly does decrease the risk of lymphedema. So this has been excellent for our patients. However, there are still times when we have to perform life-saving and incredibly important treatments to get rid of the cancer that still cause lymphedema, even in this modern age. Some of the things that cause lymphedema are surgery, where we are removing a lot of the lymph nodes, but there is also a large role for causing lymphedema with radiation treatment. And unfortunately, we know that patients do better with some of these treatments in certain situations. So I want to actually predict when lymphedema might become a problem for the patient, and then definitely be proactive about diagnosing it and certainly proactive about treating it so the patient can have the better outcomes. And obvious examples of times that I might be a bit suspicious about the development of lymphedema is when I'm having to do an axillary dissection for a patient, or when my patient has to have radiation either to the axilla or probably the chest wall, and if there are patient factors as well, like a patient's carrying a little bit too much weight. So I guess knowing where your starting point is just a no-brainer, to be honest. It's the best foundation for the successful management of lymphedema. We need to know what the baseline is so you can then monitor a change. It's just such a basic principle that it is a bit unusual why we don't do it more. And I think really, not trying to make excuses, but there's an awful lot of stuff going on when you're starting off treating a patient for breast cancer. There's a lot of new information for the patient to take on board. There's a lot of explanations about really important treatments that need to be undertaken. And so to factor in another, I need to get this patient having a preoperative assessment with an L-Dex is just another step to throw into that mix. And sometimes it can be a little bit overwhelming for, I think, the patient as well as probably the doctor who's looking after them. But I think we need to lift up the importance of doing something like this in certain patients to get a better outcome. So I think it is something that we should be doing. It's a good opportunity to accurately decide who does need the treatment and to treat it early. I think because there is quite a bit of concern from patients about their risks for lymphedema, sometimes they'll go down that pathway of anxiety about it, or go down the pathway of potentially treating it when there's not actually a major issue or a major problem there. So by being able to accurately diagnose a problem, we can not only treat the patients who actually have a problem, but I think it's just as important to be able to say to the patient, you don't have a problem, your measurements are fine, and we've got really good objective evidence that this is your assessment before you had treatment, and now this is your assessment after you've had treatment, and you're in the same ballpark. So I think that ability to tell someone that they're okay is just as important as that ability to diagnose a patient with early changes and to get on to treating them. We know that treating them early gives the better outcome. So if we can achieve this for our patients, I think it would be outstanding. And I guess that comes down to the last point, which I haven't really committed to the slide, is that as patients, you need to be an active part of your treatment process. So if your surgeon or your oncologist is busy talking about the intricacies of some of those other things, like what surgery needs to take place or what chemotherapy or radiation needs to take place, be informed, be aware that something like this exists, and ask whether this needs to be a part of your treatment. Do you need a preoperative assessment of your L-Dex? And hopefully your treating team will jump to the conclusion that I have, that it's an important part of your assessment. Thanks.